Good morning, guys. I hope you can hear me clearly. Sorry, so today I'll be hosting this meeting, but forgive me for the background noise. We're currently traveling back to Nairobi. But I think we can begin because our presenter has just joined us. And let me just give a brief introduction. Like I said, my name is Mutua Mbuvi. I am the host for today's meeting. And our presenter today, he is one of the senior orthopedic trauma technologists at Kenyatta National Hospital by the name of Zachariah Kimengich. He currently has 18 years experience in the management and fixing of fractures, especially in the emergency department, but also had some stints in the orthopedics ward as well. He trained at the Kenya Medical Training College in Nairobi, has a diploma in orthopedic trauma. And one of the things that has been outstanding about Zachariah is that he was able to come up with an innovation called the pediatric hip with double extension traction, which is one of the things that he's going to discuss today as he continues with the presentation. He has been able to take this innovation and presented it at major conferences in the UK, in London, and also in Kigali, Rwanda. And through this hard work, he has been given several awards, especially from the head of department of the orthopedics department in KNH, and also from the CEO of Kenyatta. But the most outstanding one is the Order of the Grand Warrior, which he received from the President of the Republic of Kenya. So without much further ado, I would like to welcome Zachariah to begin his presentation. Thank you very much. I'm seeing there's someone called Peter Chege whose hand is up. Peter, do you want to ask a question before we begin? Or okay, maybe that might have been an erroneous one. Zachariah, I think you can begin. Thank you.
Yeah, thank you very much, Dr. You can hear me?
Yes, we can hear you clearly.
Yeah, thank you very much. Allow me to thank you for that explaining my work. So today I'll be able to take you guys on an approach to common fractures in emergency department. Thank you for joining this Zoom. My name is Zachariah Kimengich, orthopedic and trauma technician, technology at Kenyatta National Hospital. I've worked for the last 18 years managing and fixing fractures. So you can actually see the experience that we have, especially Kenyatta National Hospital being a referral hospital in Eastern Africa. So we receive a lot of patients from actually across the 47 counties. But we want to thank the government, at least nowadays, most of the health has been devolved, which most of our doctors, the team, are now be able to manage most of the fractures in the county. So this is where I'm working together with the team that are working in at Kenyatta National Hospital. So this is the accident and emergency department where I'm working. You can see that is an ambulance where we normally receive patients who have been brought to the hospital by ambulance, brought even through the Mkokoteni, others are brought even walking. We receive a lot of the patients in accident and emergency department, that is the Kenyatta National Hospital, because that is where we get a lot of patients. So allow me just to know, it's important to know the definition of a fracture, because I believe a lot of you guys who are working at accident and emergency department, you receive this patient who comes with various bone that has broken, either the lower limb or upper limb, either children or even adults. I believe, and especially now the border has really caused a lot of accident, a lot of the trauma in this country. So we see a lot of patients who comes in our hospitals in various counties with various bones that are broken. So I believe you see these patients who comes in those hospitals, and it is very important to have a basic knowledge, and it's good to know how to manage. How do you identify that this bone has broken? So just brief definition on anatomy. A fracture is a break in the continuity of a bone. So this is a brief and a simple definition of a fracture. So the moment the patient comes at accident and emergency department, you'll be able to see how does this bone present. So you'll be able to see as definition by assessing this patient, you'll be able to know this part of the bone has broken. And actually, you can actually be able to see in this picture, you can see this is one of the femur bone that a patient has come and an X-ray has been taken, and you can see there is a bone that has broken there. So another definition, you can actually define a fracture is a break in any bone in the body. Very well, you know that we have 207 bones. So any part of the bone of the body can be able to break. So it's good to identify as a team that are working at accident and emergency department because when you are assessing your patient, when a patient comes, especially the trauma patient, those who have come from unseen, and actually when you're doing your assessment, it's good to be able to identify and be able to know which part of the bone has broken. And that is where now, after you've known the part of the bone that has broken, you'll be able to know what are the steps that you'll be able to know how to manage. So allow me to take you through the causes. We have various causes of the bone. When the bone breaks, we have various bones causes. One, patient comes at maybe explain that maybe there's a direct blow, especially when there is maybe a fight, maybe patients are, maybe people are fighting, maybe people are exchanging some few things. So one of the cause that cause a bone to break is a direct blow. So we get these patients who comes at accident and emergency department explaining how they were doing, and some they'll be able to tell you they were maybe playing, they were even maybe exchanging some of the blows. So this is one of the bone, this is one of the cause of a bone that can be able to break. Another causes of a bone to break is crushing force. This is also one of the causes that actually can be able to cause, especially maybe through maybe road traffic accident, various causes, especially when it's a high energy force. So you can actually expect a bone to be able to break. Then we have what is called the sudden twisted motion. Probably maybe when, especially maybe playing, maybe you've fallen. So this is one of the causes that can actually cause a bone to break when there is a sudden twisting motion. And another also a cause of a bone to break is extreme the muscle contractures. So sometimes you can also have this when you are probably during massage, maybe during an exercise, maybe during even a gym, because of extreme the muscles, sometimes you can actually get some of these bone to break. So these are few causes of a fracture to be able to break. And we have so many causes of a bone, like even falling from a height, maybe jumping. There's so many causes of a bone how to break, which I know you'll be able to get this history when a patient comes, especially at accident and emergency department. You'll be able to get how did this patient, how did you get this bone to break? The patient will be able to give you how he sustained this bone break. So these are very few cases, and I believe those who are working at accident emergency department in this country, you'll be able to get various causes. Still, we have what is called the types of fractures. When a patient comes at accident and emergency department, we have various types of fractures. And actually, one is to get, is this a complete fracture or incomplete fracture? So when you say a complete fracture, definition is say a break across the entire cross section of a bone. So when you try to see this type of a bone, probably this bone is a femur bone. When it's a complete, is when actually it's a direct. This could be a very high energy force. So it's when a bone break across the section of the bone. This is a complete. You can be able to see when the bone is a complete after an X-ray has been taken. So this you'll be able to say this is a complete fracture. Then we have what is called incomplete fracture, whereby a break occurs through only part of a cross section of a bone. At times, this could be a very low energy. So it depends. You can be able to see in this bone here, this is incomplete. So when you try to see a complete and incomplete, you can actually be able to know now this patient has come with this kind of a bone that has broken. Then now you'll be able to know how to manage this kind of a fracture. So we have a complete fracture, and then we have incomplete fracture, depending on, is it a low energy or a high energy? So these are patients that we get at accident and emergency department who comes in our hospital, coming with this history, giving you how it sustains some of this fracture. So you can be able to get a complete fracture or incomplete fracture. And then after knowing that one now, you'll be able to know, how do I manage this kind of a fracture? So it's good to understand, is this a complete fracture or incomplete fracture? Now, as we continue also, because we in accident and emergency department, we get still various types of a fracture. So when a patient comes, especially maybe at observation, when the patient has brought from the ambulance, then now you are able to receive this patient. So you'll be able to get to know, is this a closed fracture? Is this a closed fracture or an open fracture? Now, a closed fracture or a simple fracture is that does not cause a break in the skin. So when you try to see, I've actually shown, these are the two bones. So we have what is called an open fracture. You can be able to see this, you can be able to see the bone has actually come out. And then now you can be able to see this is called a closed fracture, whereby this one does not cause a break in a skin. So you can be able actually to see in this picture that now this one, there is no break in the skin. Now, when a patient also comes with an open fracture or a compound or a complex fracture, is when which the skin or muscular membrane would extend to the fracture bone. So these are the patients that we get in our accident and emergency department, comes to a broken part of the bone. And when we see this is a closed fracture, how do you manage this fracture, or how do you stabilize this fracture? When a patient comes at open, when it is an open fracture, how do you handle? It's very important for those who are working at accident and emergency department to know, when a patient comes with a closed fracture, how do you initially stage? How do you manage? And when a patient comes with an open fracture or an open, how do you manage? Very important at initial point, depending on how do we really be able to manage this patient, is very important at our accident and emergency department. So it's good to have a basic knowledge. It's good to understand how to manage these patients, so that at outcomes of this patient, at the end of it, it will be good for our patients to be able to get well and be able to use their legs or even part of their bone. So it's important to have a basic understanding and knowledge on how to manage these patients at initial point at accident at emergency department. So it's good for those, especially for most of you guys, doctors, nurses, the trauma guys, for us who are really seeing this patient at accident and emergency department, to know how do you handle and how do you manage? And do we understand when a patient comes with an open fracture, do we understand how to handle this patient? How do you manage this patient so that we can now be able to give the outcomes well? So allow me to take you through still part of this fracture that we see at accident and emergency department. So we have like a green stick fracture, a fracture in which one side of a bone is broken while the other is bent like a green stick. This is after an X-ray, especially the children who actually break part of their bone. So this is called a green stick. It is actually incomplete. most of these children who comes at accident and emergency department, because of the low energy force, after an X-ray, or even when you see it clinically, it is not complete. So it is good to know, as I'll be able to take you through, how to immobilize some of these fractures as we go in the various in the slides that to come. So it's good to know, even in children that comes with a green stick or incomplete fracture, how do you immobilize these patients, or how do you manage this patient at accident and emergency department? So it's very to know how to manage them, because so that you don't cause more harm. Because one, we need to know when we manage these patients, we'll be able to get relief. These are still part of the fracture that we normally get, like this called a spiral. Fracture is sometimes called a tension fracture, in which a bone has been twisted. So these are a few photos or image I've shown you that patients who normally present after an X-ray has been taken. So this is a twist, it's called a spiral fracture. You can also see this is also a spiral fracture. Same at the foot. Patient, sometimes you can also see this. This is an X-ray of the foot. And actually you can be able to see there is a fracture here. It's good to understand. So now this is called a spiral fracture. Comes because of a twist. And especially especially the foot. Probably for those like police, those athletics who normally run, times we get who comes at accident and emergency department and complaining that, giving a history that, okay, I was running, I twisted. So these are some of fracture that we normally get after a patient comes presenting at accident and emergency department. So this is good to know. How do we manage? How do you handle? How do you immobilize when you get like a spiral fracture or some like even a green stick fracture? It's good to know how do you immobilize this fracture. It's very important at initial stage. So this is also another fracture that we normally also get at accident and emergency department, called comminuted fracture. Very common fracture, especially on high energy force, especially nowadays. This border or motor bike circles that really nowadays it has actually it has really helped, especially the young people, in terms of creating employment in our country, but also in the other side, I think because of lack of maybe rules, not following the rules very well, not following really the traffic rules, we get quite of these guys getting a lot of these fractures, and they really been brought at accident and emergency department. So a fracture called comminuted is which a bone is broken and especially splinted or crushed into number of pieces. You can actually be able to see, this is just a photo of a patient who came. This is a femur fracture, a patient who came with, after a border crashed, collided with another lorry. So you can see this is a very bad fracture, and you can see some fragment there. So this is a comminuted fracture. You can also see this one is also a comminuted fracture. And it's good to know when this patient comes at accident and emergency department, how do you handle this patient? How do you manage this patient when they arrive, been brought by probably Kokoteni, maybe has been brought by even a personal, has been brought by a private car, has even been brought by even people carrying. So when they are carrying, especially at the scene, and that's why I think it's important as a team in medics to even give an awareness of our public people on actually when they get this kind of an injury at the initial side. How do they manage when they get such kind of a fracture like this? I remember the other day there was one of our staff who got bilateral femur fracture. You can imagine bilateral femur fracture. Actually, the cases were like this, bilateral. actually involved in a road traffic accident. And when he was brought at accident and emergency department at Kenyatta Hospital, these limbs were not even splinted. These limbs were actually, you could actually see it was all of them were really open. So I think it's important to have awareness in our county or in our hospital so that our public people can be able to know how do they manage, especially at the accident scene, how do they manage these fractures? How do they splint these fractures? Because at the initial point is very important. So thank God, at least we were able to, this patient came, the team at accident emergency department at Kenyatta National Hospital, we were called, we got a stretcher, then we were able now to get splints, Thomas splints, and this patient was rushed. And especially when you get like such a patient like this patient can end up even going to shock. So it's important that when our patients are brought at accident at the emergency department with especially a fracture of the leg, especially now bilateral, these are patients sometimes end up even going to shock. So this patient, I remember one of our staff were taken to resuscitation, and very fast our team at accident emergency department of our doctors, our nurses, and us, we went because this patient was going to shock. So what happened? Went there, being stabilized. A team of the casualty department, others were putting an IV lines, stabilizing these fractures. So eventually, our staffs was able to be stabilized, and then thereafter now it was able to go for an X-ray and be able to, some of these fractures actually end up being operated. Now our patient is, our staff is working, is now very fine. So it's important to know how do you manage and how do you handle this fracture at accident and emergency department. We lose patients sometimes because of the way we handle. So it's good to have a basic knowledge, a basic understanding on how to manage, on how to stabilize such kind of a fracture. So these are still some of the fractures that we normally also get at accident and emergency department. You can get this called a transverse fracture, is in which a break is across the bone at a right angle to the long axis of the bone. So when you try to see, this is a humeral fracture, and our patient comes with a humeral fracture. How do you immobilize this fracture? Same to this fracture femur. Same, this humerus fracture, and also this tibia fibula. So these are some of the patients we get at accident and emergency department who are brought by various people. How do you immobilize this fracture? This is a question that we need to ask ourselves at the initial, as when the patient are brought at observation at casualty or accident and emergency department. Is good to understand, especially when there are transfers. These are fractures that even if you don't handle well, it tends to displace even more, and even you may actually end up even causing more harm to the patient. So it's good to understand and have a basic. This is a very good, thanks for the organizers for actually coming up with such kind of a presentation for those who are working at accident and emergency department. So these are some of the fractures that we get, and it's good to know how to manage on how to stabilize this kind of a fracture. Now, this is called an open fracture or compound fracture. We also get, is very common nowadays, especially this border. And common fractures like open fractures is which the bone is sticking through the skin, also called open fracture. So compound fracture is also called open fracture, whereby the bone are really coming out from the skin. So when you try to see, these are few photos of a patient who came. You can be able to see this is a tibia fracture. It's an injury around the ankle with an open fracture. This is also a hand, a patient who came with a crushed. All these parts, it's an open. And also you can also see another open fracture here. So it's important to understand how do you manage, how do you handle these patients when they come at accident and emergency department? So I think in Kenya or in Africa, I think it's important to understand how do you handle and how do you manage? Because a lot of challenge patient comes when we just comes at accident and emergency department. Do we clean first this patient? Which kind of a saline maybe do we use? Do we use a normal water? How do you handle this patient in your hospital? When a patient comes with an open fracture, which kind of tool or what kind of, do you use a normal saline? Do you use a running water when you have such a kind of a patient with an open fracture? I think it's good to understand and it's good to know how do you manage and how do you handle. Do you have emergency trauma theater when you have this kind of a patient who just brought at accident and emergency department? Then another question we need to ask ourselves, with a patient who comes at accident and emergency department with open fracture, how long do we take to emergency theater so that this patient can be done maybe properly surgical toilet and debridement? So I think this is a question we need maybe after this presentation. At the end of this, I believe we will learn and be able to know in your hospital where you're working at accident and emergency department, how do you handle, how do you manage this kind of a fracture when a patient comes with an open fracture? So I believe it will be a good discussion at the end of it. So when a patient comes at the accident and emergency department, of course, the very important thing is to assess. So you'll do what's called clinical manifestation. You'll be able to see when a patient comes with a bone that has already broken, either the lower limb or upper limb. First, the patient will also present with a pain because this is a bone that has broken. So one, after I normally see our doctors doing a clinical assessment, examining this patient from all the head to the toes. And actually, where especially the bone has broken, the patient will say, oh, Daktari, I'm feeling pain on this. So one of the clinical manifestations, a patient will be able to present with pain. Then there will be loss of function. You see, when the bone breaks, that particular part of the bone, it will not be able to walk. So one, you'll also be able to see that part when you tell the patient to lift or even to extend, that patient will not be able to lift or even extend. So there'll be loss of function on that particular part of the limb or particular part of the bone. Then you'll also be able to see deformity because when the bone breaks, because of the muscles, this bone will tend to be able to, you'll be actually be able to protrude, and you'll be able to see a deformity at that particular part. Then in some, like even lower leg, especially the femur bone, probably maybe the tibia, you'll be able to see some shortening. So because of the bone that has broken, you'll be able to see shortening of the limb. So these are clinical manifestation after doing your examination to your patient. I believe you'll be able to see them. There will be some shortening. Then when you try to palpate or examining that part, you'll be able to see some crepitus, and especially when the bone is comminuted. Where particularly bone that has broken, you'll be able to see some crepitus. Then another clinical, when during clinical examination, you'll be able to see some swelling and actually some discoloration. That particularly part of the bone that has broken, because of that force, you'll be able to see some swelling and also some decolorization. So these are clinical manifestation you'll be able to see. Then another part, you'll be able to also to do what is called diagnose. After now you've done your clinical assessment, you've done examining this patient, and now you want to do, how do you be able to diagnose this fracture? One, of course, you'll be able to get a history collection, physical examination, which most of you doctors, nurses, orthopedic trauma, and entire paramedic team that are working at accident and emergency department, you'll be able to do physical examination. You'll also be able to request an X-ray. Now, we normally get sometimes X-ray being requested, and maybe you leave a particular part. So I think it's important when you're doing an X-ray, be able to do request several X-rays, especially where you suspect probably this part of the bone is broken. Sometimes it normally missed, so it's important to be able to really request various varieties of X-rays. Sometimes you can also maybe you request an X-ray and the patient has brought back, you're not able to see some of these in an X-ray plane. Some I see our doctors request a CT scan and also sometimes an MRI to be able to show more of this problem on soft tissues to be able to get to understand more about your patient. So these are some of these diagnosing of a fracture, which most of the doctors at accident emergency department who are working normally request this CT scan and even MRI to be able to know more about it. Now, allow me to take you through when a patient comes at accident and emergency department, the initial fracture management. This is a very important where I remember I shared it. The first important thing is to do reduction. So it's good to understand when a patient comes at accident, when the bone breaks or when there is also a dislocation, do you reduce at initial point? It's very important to understand this. Maybe a patient has come with a dislocation of hip, knee joint, ankle joint, hip dislocation, shoulder or elbow. At the initial point at accident and emergency, do you reduce this dislocation or do you immobilize the way it is? Second, initial fracture management is immobilization. This is whereby now we do you immobilize? How do you immobilize some of these fractures? How do you immobilize some of this dislocation? It's good to understand and have a basic understanding or knowledge which fractures need to be immobilized, which fractures need to be reduced, because not all fractures need to be reduced. Not all fractures need to be immobilized. And then we are also going to discuss about splinting. This is a very important area and very important what we normally do at accident and emergency department. So this is the initial fracture management. We are going to discuss about reduction, immobilization, and also the splinting. Now, let's discuss about the reduction. Reduction of a fracture or setting the bone refer to the restoration of a fracture fragment to anatomical alignment and rotation. This is a very important point when a patient comes with a bone that has broken. Because one, when you don't align your bone, or when you don't align your bone, the bone will going to heal in malunion. So important is to be able to restore. So the first step is restore this fracture at accident and emergency department. Having worked at accident and emergency department, this is my almost 18 years managing fixing fractures. So sometimes we normally call by our doctors or our nurses when they see a patient who has come with a bone that has broken. So because of the experience and also because of understanding, is this fracture need to be reduced? Is this fracture need to be just to be splinted? So we are able to understand and we are able to get to know. So there are some of the fractures when a patient comes at the accident and emergency department, do you need to reduce? Do you need to align this bone? So this is a question that we'll be able to discuss at this Zoom, at this presentation. So one very important is reduction of a fracture, whereby we need to restore the fracture fragment to anatomical alignment and rotation. So important is we make sure that we restore and then we make sure that we align and restore that bone. So this is a very important, we'll be able to discuss at the end of it. Then we also have what's called open reduction. Some fractures at accident and emergency department, there are those that we need to manage with a cast, which I'll be able to take you through. There are those that will be able to require open reduction. So at accident and emergency department, the very important thing is to stabilize. Can we stabilize these fractures? Can we make sure our patient is more comfortable? And then there are those fractures that require to be open reduction, which is a surgical approach. The fracture fragments are reduced. So that's why we have trauma emergency theater. When we get open fractures, these are patients supposed to be taken straight to emergency trauma theater so that they can be able to be done surgical approach. Like now, a surgical toilet or even debridement. So in your hospital, how do you manage open fractures? This is a question you need to be able to maybe ask yourself. Does your hospital do they have emergency trauma theater? And how do they manage these open fractures? So this will be a good discussion at the end of it. Then now we have what is called close reduction. This close reduction is accomplished by bringing the bone fragment into opposition, placing ends to its contact through manipulation and manual traction. Because when a patient has been, after the x-ray has been taken, now our doctors, medical officers, our registrars see the patients at accident and emergency department. When they see this patient required to be put a cast, they normally send this patient to our casting room or plaster room, for those who normally call plaster room or casting room, it's the same. So when they comes at casting room or plaster room, we orthopedic and trauma, first thing we normally do is to request a doctor to be able to give this patient a good sedation. So when a patient comes, is given a good sedation, because the bone sometimes displaced, so we want to do what's called manipulation and reduction. So we are going to do what is called close reduction. So most quite of the fracture that are closed, we normally do at accident and emergency department. So we do what is called close reduction under manipulation and reduction traction. Then we are able to put some other cast, we're able to put some splints, and then those that are require open, then they get admitted. Then now, this is very important where now we do what's called immobilization. In this slide is a very important whereby now we need to understand how do you immobilize these fractures, like an open fractures or closed fractures. So immobilization may be accompanied by external or internal. So when you say immobilization, you can either immobilize this fracture externally or internally. Externally means you can actually immobilize this fracture either using a plaster of Paris. Another external, you can also external maybe using a splint, or even you can actually use Thomas splints. Those are called external. You can actually immobilize after assessing this fracture. After seeing this fracture need to be immobilized, you can actually immobilize either external or internally. Some of this internal fixation is like an open fracture, whereby now our surgeons, orthopedic surgeons, goes in, admit these patients, take this patient to theater, and put maybe internal fixation like plate, like screw. So fracture can either be immobilized externally or internally. So it's good to understand on that. Then method of external fixation include, like now external, at accident and emergency department, when a patient comes with a fracture, maybe humerus or fracture tibia fibula that are closed, fracture maybe of femur in children, maybe fracture of probably of the metacarpal or even phalangeus, or even radius and ulnar fracture, we can actually do what's called a bandage. And this bandage, you can actually have casts. That's the way I say. You can actually put a cast. After manipulation and reduction, you've seen this fracture that is displaced. You need to be able to restore that alignment of the bone. And you need to be able to, after now you manipulate and reduce, what we normally do at casting room, we put casts. So we have various type of casts, like below elbow cast, above elbow cast, below knee. We have those various kind of casts depending to the kind of the fracture. This kind of a fracture, you can also splint. Another immobilization, you can splint just away at accident and emergency department. This is whereby a patient comes with a fracture femur. You need to be able to splint. And in your hospital where you are working, or at an accident and emergency department, which various types of splints do you have? These are questions we need to ask ourselves. Do we have enough splints? Do we have splints that are able to splint the fractures of the upper limb or lower limb? So like a patient who comes with a fracture femur, we need to be able to splint with a Thomas splint. So in your hospital, do you have enough Thomas splints? Or which type of splints do you have? And if you don't have these splints, it's important now after this presentation, at least now you'll be able to maybe make a request for your hospital to be able to have this type of splint. It's a very important splint to have at accident and emergency department. So for those who are working at accident emergency, of course, all of you now that are watching on this Zoom, do you have enough Doma splints in your hospital? And which type of splints do you have? Because you need to have splints for the children. When a child comes with a fracture femur, do you have the splints for the child? When a child comes with a fractured tibia, do you have that particular splint? When a child comes, or maybe fracture even of the neck, or even the fracture of the leg. So we need to have various types of splints for the children and also various types of splints for the adults. So that when a patient comes with kind of a fracture, hello? Somebody talking? Hello? You can hear me?
Yes,
hello?
Zach, we can hear you. We can hear you.
Oh, thank you. Somebody, I just had somebody speaking.
Oh.
Yeah, thank you. Thank you. So I was talking about various type of splints that we really need to have in our accident and emergency department. So it's good to order this type of splints so that at times, like even when we have a mass accident in our department, we were able to handle this kind of a fracture when it comes in our department. So another method also, we have what is called the continuous traction. So in our hospital, we have these traction patients who are getting admitted, patients who get put on traction, and understand that there's still a big challenge in our county hospital. Some of the hospitals don't have orthopedic wards. So when a patient comes with a fracture femur or even other like cervical injury or even a patient with an open book, do we have orthopedic beds? Do we have orthopedic wards in our hospital? So that now we can have what is called continuous traction while we are going to immobilize this patient. Because some of the fractures, we cannot be able to manage at accident and emergency. Some fractures we need to be able to admit so that it can now be able to be done further management. Then another one is to have what is called external fixators. So some of these, especially patients with an open fractures, most of our orthopedic surgeon goes in, be able to do debridements and be able to do what's called an external fixators. So do you have these external fixators in your hospital? So these are questions that we need to be able to ask ourselves. Then we have what is called the metal implant used for internal fixation, serve as internal splints or immobilize some of the fractures. So basically about immobilization, we need to have enough tools to be able to enable us, those who are working at accident and emergency department, to be able to handle all the cases, all the fractures that comes at accident and emergency department, to be able to be mobilized well. Now, allow me to take you through, these are some of the immobilization splints at accident at Kenyatta National Hospital. These are some of the splints that we normally have when a patient comes, like this is called the cramp splints. So this is called the cramp splints. And I don't know in your hospital, do you have this called the cramp splints? it is like a wire. Actually, it's like a wire, and it can be able to be bent. You can now be able to bend in any angle. This is a very nice splint. Do you have in your hospital so that when you have a patient like radius and ulnar, fractures of the hand, or even fractures of the humerus, do you have this kind of a splints? And if you don't have, it's important to be able to present to your hospital so that they can order, so that when you have this kind of particular fracture, you can now be able to manage this kind of a fracture. Another immobilization splints, you can now be able to see this. This is at Kenyatta National Hospital. You can see this is called a Thomas splint. We were trying to splint this patient. First, you need to be able to pad using either a gauze row. You can actually use even a crepe bandage. So you have to make sure that you prepare your splints at any given time, because you see, accident and emergency department, this is an unpredictable department whereby at any given time you hear there is a mass accident, there is an explosion, there is this kind of a disaster. So we need to ask ourselves, are we prepared? Do we have the enough splints when a disaster or a mass accident comes in our accident and emergency? Do we have these tools that enable us to be able to splint when a patient comes? I remember during the bomb blast, that is in 1988, if I can still remember, all the patients were brought at accident and emergency department at Kenyatta Hospital. Thank God, at least we were prepared. We had like almost 200 Thomas splints, Thomas splints for the lower limb, Thomas splints for the upper limb, and even some of these splints, we were really prepared. And when patient comes, we were able to handle them, and we were able to manage them and be able to immobilize them. So ask yourself, in your hospital at accident and emergency department, are you guys prepared? Is your hospital prepared? So this is a question that will be able to be discussed. So these are some of the splints we normally have. Various design, various size, depending to the age, depending to the weight. Actually, it's important to have various types. So I believe at the end of this presentation, we will have learned and be able to see, ask ourselves, is our hospital equipped? So this is how to immobilize fractures. This is a team at accident and emergency department. Allow me, this is one of our patients who came with a fracture femur. You can see this is a team of a doctor. We have a nurse there. We have the entire team. So what happened at, especially at Kenyatta Hospital where I'm working, accident and emergency department, when we have a patient who has broken part of their bone, all of us, the team are there. And we're able now to be able to stabilize, get the right type of the splint, get how do you give that traction so you can now be able to see. We have also our students who are able to also learn how to immobilize, how to stabilize, so you can be able to see. This is an entire complete team. So when a patient comes who has broken part of their bone, do you call all the team at accident and emergency department? So this is a question that you need to be able to ask yourself. Do you have the team that is able to handle these fractures? So I can also be able to see, now this is a patient who came with a fracture. Actually, this is a patient who came with a polytrauma, who came with a fracture of the tibia, he came with a fracture of the femur, and actually a patient came with a fracture of it's called an open book of the pelvic. So when a patient comes with a polytrauma, how do you handle this kind of a patient? How do you manage this kind of a patient? How do you immobilize this kind of a patient? Require a multidisciplinary team. Do you have a multidisciplinary team in your hospital? When you have these polytrauma patients, this is a question we need to ask ourselves. How do you handle? Because very important at the initial point, depends on this patient, on how we are going to handle this patient. Sometimes I see how we handle patients at accident and emergency department. Do we handle well? So it's a question that we need to be able to ask ourselves. And I believe at the end of this presentation, we will have learned how do you handle these patients who comes with a polytrauma injuries. Very important, like now for this, who came with a fracture femur and a fracture tibia. So what we did at accident and emergency department, we got a Thomas Splints, the right Thomas Splints for this patient. Because we have various type of splints, various type of Thomas Splints. So it's good to be able to get the right Thomas Splints. So first we were able to prepare a Thomas Splint. One of the team that is able to get a GOSRO. There's another team that is able to give it's called a traction. So because of the pain and because of the bone that has broken, we need somebody to give a nice traction. So how to immobilize, especially fracture femur, you need to be able to have a team. And that's why you cannot be able to immobilize alone. And that's why you see here, we are around a team of around 6'5". One is giving a traction, because the moment you give a traction on this fracture femur, one, the patient pain get relief. One, you are able to align that bone. So the idea for giving a traction is one, you need to be able to relieve the pain, align that bone, because when the bone is broken, you need to be able to align. And by aligning it, you need to give good traction. And by giving traction, now you want to see how are you going to restore, how you are going to align that bone. So this patient, we were able to put a Thomas Splint, and then with the fracture tibia and then fracture femur, it was able to immobilize fracture tibia and fracture femur. Now you can be able to see that is one of our doctor was trying to be able to splint it. He's using actually a GOSRO. You can either use a GOSRO, you can actually use even a clay bandage. So we want to make sure that we stabilize this patient. Now, this is also a patient who came out with an open book. How to immobilize an open book, which are very common in our hospital, very common at accident and emergency department. So how do you immobilize? How do you manage this open book? So most of our hospitals at the county, or even most of our hospital, we normally use. What kind of a tool do you use? How to immobilize an open book? So you can be able to see we were able to use what is called a liner sheet, which I believe most of the hospital normally use this liner sheet. But we need to ask ourselves, is this the right kind of a sheet to use? When a patient comes with an open book. Secondly, you can now be able to see, how do you position? How do you handle when you're putting a patient on a pelvic binder, or when you're putting that sheet? How do you handle, or how do you manage this patient? So it's very important on how, in terms of positioning, how do you handle this patient so that you don't cause more harm? So you can be able to see, when we started here, you can be able to see we were able to immobilize and stabilize there. And then now, this patient with a polytrauma, we had what is called a spine board. Now, a question we need to ask ourselves, does your hospital has a spine board? Because this is a patient with a polytrauma. We suspect that this patient could also be having a spine injury. Do we have a spine board in your hospital? Now, this patient, I say he came up with a polytrauma. He also came up with a fracture of the radius and ulna. And then actually you can be able to see, how do you manage a forearm fractures, or how do you manage a forearm injuries? So you can be able to see, we were able to splint. You can be able to see, we still need to splint this patient with a fracture of the forearm, because we don't know. This could be a fracture of the radius and ulna, could be probably a fracture of an ulna, either distal, shaft, or proximal. But first, we need to be able to immobilize and be able to stabilize. And that's how you can be able to see in the next slide, we will now actually be able to use a special add material to be able to splint this particularly part of the forearm. making sure that we give a traction, patients to be able to make sure that it doesn't feel any pain. So we were able to immobilize that forearm. Now, this is a patient who came also with a hip dislocation. I believe in your hospital, patient comes with the various dislocation, either a shoulder dislocation, hip dislocation, knee dislocation, ankle dislocation. Any dislocation can be able to occur at any joint. Now, how do you manage this dislocation and how do you immobilize? It's very important to be able to understand how to immobilize dislocations at accident and emergency department. So like for this, what we did after an X-ray has been done, so we done what is called a reduction of hip dislocation, and then we were able to strap both limbs. So you can strap both limbs there using a gauze rod. You can actually use maybe a clay bandage, and then this patient will be able to be admitted in orthopedic ward so that this patient can be put on a skin traction probably for 3 weeks. Another thing you can also, after you've reduced probably maybe this hip dislocation, you can actually apply what is called a Thomas Splints, whereby we have what is called a fixed traction. That's sometimes we normally do. So it depends, do you want to strap both or you want to put a Thomas Splints? So you can actually do either so that actually to be able to immobilize that hip. Now, allow me to take you through. We also get some patients who come with a fracture, especially children. How do you manage fractures of the thigh and pelvic injuries in children? Very common in our accident and emergency department. When a patient comes with, when a child comes with a fracture of the thigh or femur or pelvic injuries, how do you manage these children in your hospital? So allow me to take you through how what we normally use before the innovation. I'll be able to take you through. Before the innovation, this is how we were using. We were improvising this kind of materials. When a child comes with a fracture femur, these are called jerrycans. We were immobilizing the child, positioning the child. You can be able to get people holding the both limbs, holding the shoulder there. It was very difficult. This is also another method that we were using it because of the lack of equipment. I believe in our hospitals, and especially now the county has been devolved. Do we have the right equipment to manage fractures even in children? Do we have the right tool, or we still have the old tool that we normally use? So like for us, this is what we are using it. And I believe actually most of the county hospital, orthopedic department, they still have a big challenge in managing fractures in children. But good news, we've come up with an innovation now that we are able to manage most of the fractures in children. So it was very difficult to manage thigh or even the pelvic injuries. Most of the children were able to admit. We need to ask ourselves, when you admit a fracture pelvic or a fracture thigh, 2 years old, 3 years, 1 year old, very expensive to most of our parents. Can they be able to afford even to this admission? So allow me to take you through. This is what the problem of not having the right equipment, the problem of not having the right tool. This is a child who came with a fracture femur. That is a child around 2.5 years, 3 years, who came with this fracture. And because of we were using this tool, and we don't have the right tool, what we did, the child was put on a hip spiker, and we sent this child to an X-ray. Now, see the check X-ray, the results. It is still displaced. We need to ask ourselves, do we still continue to have this kind of thing? So it's a big challenge, and this will end up a child getting admitted. Now, Implication of initial bone alignments or method used to improvise the tools. I don't know in your hospitals, what kind of the tool do you normally use? So the problem of having improvised is poor bone alignment. Actually, like that one, because of lack of the equipment or because of lack of the tool, you'll have what is called the poor bone alignment, increase in the number of the deformities because of the lack of equipment. If you don't have the right equipment, you'll be able to have a lot of deformities. Increase in admission. Most of the children are getting admitted. Why? Reason, lack of equipment. Some of the children we can afford, we can actually be able to manage at accident and emergency department and be able to discharge if we have the right equipment. But most of them are getting admitted because of the lack of equipment. High number of the surgeries. Some children end up being done surgeries unnecessary, something that actually we could have reduced if we had the right equipment. Increase in disability resulting from the bone alignment. So these are some of the implications because of lack of poor equipment or poor improvisation. This is what is normally done. Now, allow me to take you through the journey of our innovation, how we came up with this innovation of hip spiker table. In 2015, I was able to visit one of the hospitals called Kijabi. You know, all of you know, or even those who normally comes from Kijabi, I went for a training about Ponset. That was in 2015. And after the training, I was able to see this tool at Kijabi Hospital. You know, this is one of the hospitals that they receive a lot of hospitals. These are a lot of surgeries, a lot of visitors from UK, US. They normally go and operate. So they had this kind of a tool, this kind of the hip spiker table, and this is what most of the Kijabi hospital were using it. And I was able to take actually a photo, and I want to appreciate Kijabi Cure Hospital. This is what they were using it to manage fractures of the femur. So we were able to modify it in our hospital in 2015 and in 2016. So having used this modification, the first modification of the spiker table, there was still a problem. We were not achieving our bone alignment. Now, in 2017, we improved it. Actually, I was able to discuss because we were still getting a lot of challenge. Most of this was still admitting most of the children. We were still getting a lot of deformity. We were still getting poor bone alignment. So in 2017, I was able to discuss with one of orthopedic surgeons called Dr. Peter Kamau Njoroge. He's also an orthopedic surgeon at Kenyatta National Hospital. And I went and shared about this kind of a challenge that I'm actually getting it. Then the doctor told me, yeah, I think, Zakaria, we can be able to improve. And actually we went ahead and be able to improve this to be a stainless single hip spiker table. And we got excited, and because we started using this and we saw, yeah, this is we were able now to reduce some of these admission, and we were able now to align some of this bone. Now, this is one actually, that's what made me even to go to UK. So I'll be able to share with you on that. So in 2017, 2018, we were able to improve. Now, this is what made me to go to UK for Leaders Innovation Fellowship Program. We have in Kenya called Kenya National Innovation Agents, whereby they support innovators. So they put an artifact at 2017 telling anyone who has come up with an innovation. So what I did, I just put that artifact there. I just applied. And then at around December 2017, I was surprised that I've been nominated to participate at the Royal Academy of Engineering in London. So with other innovators in Kenya. So what happened, we went to UK for 2 weeks, and then we were trained. When I came back, we were able to improve, still discuss with Daktari, because we had a single, then now we were able to improve. this now to become a double extension traction. So with this one now, we were able to manage, even if a child comes with a thigh fracture, even if a child comes with both bones that are either thigh or even pelvic, we were able now to manage children who comes in our hospital with this kind of an injury. So we were able to improve and be able to use it in 2017, 2018, and 2019. It was amazing. It was amazing. So we were able to improve. Actually, after coming back from London, we still be able to improve this innovation. And I think maybe I was able to impress with our UK guys. They support innovation. And actually, that's why they've continued supporting this innovation. And actually, you can now be able to see this one now called the hip spiker table with a traction mechanism. We were able to improve now more better from 2015, 2017, and 2019. So now we are able to improve now in 2020 and 2021 and be able to add to a mechanism now that is able now to give it a nice traction. And this is just because of the support we are getting from the UK. Now, what are these advantages? When we came up with this innovation, what are the advantages of innovation? And because we are actually in the era of innovation, I will actually request, we embraced innovation in this country. We are going to move forward. We are going to do a lot when embraced innovation. So when we came up with this innovation of hip spiker table, what does it has happened when we came up? One, what now is we're able to do what's called the optimum bone alignment. So we're now able to align bone alignment because now we are able to manage this bone well. Secondly, we are now able to reduce hospital admission. So now we are now able to reduce most of these children getting admitted. We are able to manage these fractures at accident and emergency department, casting room, and be able to discharge and be able to follow up. So we're able to reduce hospital admission, reduce turnaround time. So we're able to reduce turnaround time. We're able to reduce cases of deformity because we're able now to align the bone, restore bone alignment, and now we're able even to reduce surgery. So actually, when we came up with this innovation, these are amazing. We've been able to reduce all this. Now, allow me to take you through various bones fractures that we've used using this innovation. You can actually be able to use this innovation. It's an amazing machine, locally made, affordable. We no longer now need to import. Importing is very expensive. As you know, most of our hospitals in this county, or even you can see the national government, importing a lot of equipment is very expensive in this country. Can your hospital be able to afford to buy some of these equipments? Like I was able to send an email to US, just this hip spiker table. Can you imagine this hip spiker table? It is in US. Do you want to know how much they are costing? 500,000 shillings, Kenya shilling. That is handling, shipping, and I just wanted to find out if I was to import that hip spiker table, how much is it? Very expensive. But good news, we have it now here, locally made, very affordable, very accessible. So this is one of the femur that we used. You can now be able to see. This is a child who came up with a fracture femur. Amazing. We were able to use the hip spiker table. And actually, you can now see the alignment. We were able to use it. It's an amazing machine. You can have it in your hospital. So this is one of the, after now you put the hip spiker table, you can get 1.5 hip spiker table. This is how to put a hip spiker table. You can have what is called bilateral or double hip spiker table. And especially now with the hip spiker table with the extension traction. Hello? You're still getting me? Hello? You can get me? Yeah, thank you. Yeah. I'm almost. So this is a child who were able to put a double hip spiker table using a double. We were able to use this. We were able to use this double hip spiker table with a mechanism We were now able to actually align this bone well if you have that right equipment. So we were able to put a hip spica table and be able to discharge this child. And most of these child now are able to go back to school. Now, these are various also application of the cast. You can be able to see after you align the bone, you can now be able to put a cast. So you can now also be able to see this is a child who is also a patient who came with a fracture collis. You can now be able to see this. This is a collis fracture. And we have also called a traction table, whereby we were able to use to align this bone. It's an amazing. Guys who are working at accident and emergency department, if we don't have the right equipment, most of these fractures we cannot be able to manage well. So I encourage that we actually push our hospital. We have the right equipment, the right tool, so that we can now be able to manage most of these fractures and even reduce some of these surgeries. So you can now be able to see this is a patient with a fractured femur, bilateral. So can you imagine if you don't have the right equipment, this child you are just going to admit, put this child in skin traction for 6 to 8 weeks, very expensive, or even others going for surgery. Do some of these public parents be able to afford some of this money? Some they don't have NHIF, very expensive. But if we have this kind of the hip spica table or some of these equipments, we can actually be able to manage most of these fractures and reduce what we've said. This is also another fracture called radius and ulnar. In the accident and emergency department, Kenyatta Hospital, we have a table called traction table. Amazing machine, amazing table. We were able to manage reducing this kind of a fracture. Some of these fractures sometimes end up being operated. But if we have the right tool, if we have the right equipment, we can actually reduce some of these cases and be able to save. Because most of our diseases are developing country. Now, this is kind of a fracture called the metacarpal fracture. Sorry for this typing. This is called a metacarpal. A patient who came up with all these metacarpal fracture. How do you manage this kind of a fracture? Is it closed? Is it open? How do you splint? Very important to know when a patient comes at accident and emergency department. So this is how the patient came. You can actually splint. Important thing about splinting is to have hard board. You can even use a carton. Like this is a patient who came, I think it was actually a referred patient. I don't know, from one of the hospital. So he was actually referred and they were able to splint. You can be able to see this is called a carton. Have a hard carton, hard board, something hard that is able to splint. Very important. So that at least before referring this patient to the other hospital, at least the splints, very important to splint at accident and emergency department, so that this patient can actually move very comfortably. The pain will have actually been able to reduce. Okay, so this is the traction table I was telling you guys. This is what we normally use at Kenyatta National Hospital. Amazing table, amazing table. We'll be able to reduce most of the fractures. We've reduced the surgery. We've reduced a lot of cases, even going for surgery. So it's an amazing machine. I wish and recommend whole hospital at accident and emergency to have this kind of an equipment. Now, we have a big problem. This is my last slide. You know, most of the fractures that comes at accident and emergency department, what we normally do, the ideal we normally reduce, we normally manipulate these fractures blindly, which is very wrong. In developing countries, what they normally use, they have what is called the imaging intensifier. Do we have imaging intensifier in our hospital? Or even at accident and emergency department, especially casting room, where the fractures are normally reduced and manipulated? Which do you have this imaging intensifier? How do you reduce these fractures in your hospital? Do you use imaging intensifier? How do you use? All right. After working at accident and emergency department for those years, I've told you 18 to 19 years, this is also one of the gaps, and also this is one of the challenge I saw. One, you reduce fractures blindly. You are not very sure. You send this patient for check X-ray. When a check X-ray comes, bone is not reduced, you get very disappointed. So what you do is, what you normally do, you have to tell the patient that we have to remove this cast, you have to manipulate again for the second time, and even this second time, we are not very sure. We are going to give more sedation. This patient will be able to undergo a lot of trauma. But I deal the standards that when I ask the radiology department or even our orthopedic surgeon, the standard is fractures need to be reduced under imaging intensify so that we can now be able to see the alignment. Now, the other day, I was also able to share with the same doctor called Dr. Peter Kamau Njoroge. I was also able to share with the Dr. Chomba, who is also an orthopedic surgeon. I asked them, Daktari, we're having a big challenge. We reduce fractures, we manipulate fractures, we put cast, we put splint. We send this patient for check X-ray, but when the patient comes, when the check X-ray comes, fracture is not reduced. You get very disappointed. You are not happy about it. Even the patient is even asking, hey, Daktari, what is happening? You are going to reduce again. You're going to manipulate again. The patient is undergoing a lot of trauma. So Dr. Kamanjoroge is one of the doctors who is actually, he's one of the chairman of AO. It's called the AO. He travels a lot in this country. So when I shared with him, he told me, Zakaria, he saw an ultrasound being used in Canada when he went there for to give a presentation. So actually he shared with me and told me, yeah, Zakaria, I think, can we try to see whether an ultrasound point of care can be used in guiding in fractures? So what I did is I was able to go to radiology department at Kenyatta Hospital, go share this idea to them. And I want to thank Dr. Thieno and the team that were there. They were impressed and told me, yeah, Zakaria, I think, yes, we can use an ultrasound. It is possible. They were very positive. I want to thank them for having a positive and be able to actually say, yeah, I think we can start and we can see. So this is an idea that we came at Accident and Emergency Department, casting room. We have a team of orthopedic surgeons together with us and our radiology department. So we came up with this called the point of care ultrasound, which is POPs, used in fracture reduction. So for ideal fracture reduction, imaging intensify is required during fracture reduction. That's what I say. But do we have it in our hospital? Do we have it in accident and emergency? So due to radiation, about imaging intensify has a high radiation and very expensive to purchase. How many hospitals have this imaging intensify? So we came up with what is called point of care ultrasound at Accident and Emergency Department, Kenyatta National Hospital. You can actually be able to see this. Guys, it's an amazing. So far, we came up with it last year. We started last year, 2019, 2020. So far, we've actually started and we've seen over 100 patients with this point of care ultrasound machine. And we are now able to use this ultrasound in guiding of fracture reduction. So it is a study we are working, it's a study we are doing. We are going to present, we are going also to write even a paper and be able now, this is a study we are doing at Kenyatta Hospital. And after we've seen, what we normally do, we compare. So we see when we put a patient on when a patient comes with a fracture, either femur, tibia, radius, mention in it, before we put a cast or before we put a splint, our guy from radiology is now able to put a prop and be able to show you. So you can be able to see this is a displaced fracture before reduction. When we do the reduction, you can actually you can appreciate now putting the prop there. You can now be able to see the bone is aligned. It's an amazing thing. Now, see, this is a patient we were using, a patient who came up with a fracture. So before we do the reduction, our sonographer guy or the radiologist or a radiologist guy is able to put a prop there. Then we able to manipulate the fracture. And then now you can be able to see. So before you put a cast or before you put a splint, we are able to manipulate first. This is one of the patients we are doing it. You can actually see this is alignment. We're able to achieve the alignment. It's an amazing. So allow me to take you through. This is one of the few cases. We have so many cases that we've done. We're actually going to present in a very biggest conference in October, in one of the orthopedic conference in Kenya, whereby most orthopedic surgeons normally comes within and outside. So we are going to present this. We are going to write a paper. We are going to actually even to put it in a channel. This is a study we want to do. And then we are going actually to also, even the county, those who are working at accident and emergency department, sell this idea so that at least they can now be able to manage fractures without blinding. So this is a patient who came with a fractured distal radius. You can see this one. So you can actually be able to see good alignment. This is now, we normally do the check. So we do it during the process, during the manipulation. You can now be able to see this. We have even photos there. And then now we want to confirm whether an ultrasound with a check X-ray, is it the same? So this is a comparison, and this is the study we are doing it. It's an amazing, guys. And I think it's an idea that's good to actually adopt it in this government or in this in our hospital, so that at least we can manage fractures more better and reduce surgery, admission, and even some of this deformity. So, advantage of point of care ultrasound, one, no radiation. You know, the beauty for this is no radiation. Second, it's portable. So what we are doing also, because it is portable, those patients that are getting even put on a traction, those patients that are put even on a skin traction, you know, we don't know exactly, we are not even sure whether this weight, is it able to reduce the bone? So what we are doing it is actually, it is a study we are doing it, so that when you put a weight to a patient who has either skeletal traction or a skin traction, do we need to reduce this weight? Do we need to add? So because it is portable, you know, this is portable. We are able to carry this ultrasound even to the wards. It's an amazing. It is a real time. Another thing advantage, it's a real time. So you see now, we came up with this idea. We are now able to see the bone alignment at a real time. Before you put a cast or even put a splint, we are now able to see, is our bone as aligned? Have we restored the alignment? If not, we continue to manipulate, we continue to reduce this fracture until we see the bone is aligned. Thereafter, now we can now be able to put a cast. Then we're able to reduce turnaround time, especially at accident and emergency department. So imagine now the patient that we get at accident and emergency department. There are so many patients. So you see, with a point of care ultrasound, it will be able to reduce the turnaround time. So I will encourage that we, like now, a lot of study I've seen in most of the hospital like Kenyatta, point of care ultrasound is normally used. Even in some of the condition, medical condition, you can now actually be able to see. So it's an amazing machine, guys. Now, this is a child who came with a fractured femur. Just remaining with a few slides. I'm almost finishing. This is a child who came. You cannot be able to see this is a child. He was actually referred from one of the hospital. And you can see the splint. You can actually see this is a fracture has already been splinted. So what we did, this child, we were able to use extension, the hip spiker table with an extension traction. We were able to use an ultrasound to guide us before putting the hip spiker cast. It's an amazing, you can now be able to see, it gives a nice traction. It's a nice traction. So imagine if you have bilateral femur, even thigh injury, you can now be able to manage using this, the hip spiker table. Amazing. This is one of the check X-ray. You can now be able to see. This is that patient who came up with a fracture femur displaced. This was a child actually was supposed to be admitted. And I think in most of the hospitals or those who don't have the right equipment, straight you'll just say this child needs to be admitted. This is a check X-ray. It's an amazing. We were able to achieve the bone alignment. Okay, thank you very much. Allow me to just tell you briefly, when we came up this innovation, there are few awards I've received coming up with this innovation. You know, it is always good. Come out from your box. See a challenge, come up with a solution. We are just using the existing. At accident and emergency department, we are using various tools or even equipments. It is the existing what we normally have. We want to improve it to be more better. So when I saw that hip spiker table, you see now we are able to improve it more better. Actually, we are one of the hospital or one of the, there is no other country has that hip spiker table that we have. It's an amazing. So coming up with that hip spiker table, go out of your way. Go out of your way. These are the few awards that I've received. One, I received this from the head of Department of Orthopedic, a recommendation. I also got a recommendation from the CEO, Kenyatta National Hospital. When I went to UK, I was able to got this award from Royal Academy of Engineering, London. My innovation got the first position. It was an amazing. Guys were amazed to see what we were using it and what we came up. And that is why up to now, they've continued to support this innovation. I want to appreciate them and I want to thank them. Now, I want to thank the hospital. I was able to be nominated. It was around 15 who are nominated, who have come up a few things in the hospital. So guys, when you are at your hospital, do something. It doesn't matter how it is. It doesn't matter, is anybody supporting it? Do it to your best. See that thing. Let it come out from your heart. So we were around 15 who were nominated by the hospital. And out of 15, you know, this is a process of award. It is not only Kenyatta. They normally receive all awards from Kenya, various organizations from various hospitals. So various hospitals present various staffs who have come up with a few things in their hospital. The question, have you come up with anything in your hospital? Have you go out of your way in your hospital? Think of something with that idea, come up with something. So what happened? It happens that I was nominated. Actually, in Kenyatta National Hospital, we were only 4 who were actually nominated. And what we got, we've gotten this is what's called the Order of the Grand Warrior. Actually, the good news, this Monday morning, on Monday 2nd, we are going to be awarded this award at the CEO monthly meeting. Otherwise, become a solution to a problem and do not become a problem to a solution. Support innovation. Thank you very much for listening. And over to you, Dr.
Thank you so much, Zachary. That has been an excellent presentation. I'm sure most of us have learned new things, especially what really got to me was a point of care ultrasound use in the management of fractures in the emergency department. This is basically because we have also started using a lot of point of care ultrasound even for emergency patients, trauma patients who come in. So it's something that is quite exciting. We appreciate the presentation. This is from the beginning, from how we begin with the management of fractures, all the way from like everything, reduction, immobilization, splinting, coming up ahead, and then doing the traction table, the hip spiker table, and now using point of care ultrasound. This is just amazing work that's happening in the field of orthopedics. Thank you so much, Zachariah, for that. I'd like to open the floor to anyone with any comments, appreciations, anything that you may want to say, or maybe just give your experience from where you come from, or even just ask questions if you must. So what you can do, you can just kindly unmute yourself, and then you can just let us know what you want to say so that you can keep this discussion going. So the floor is open. I can see there's a comment on the chats from Dixon, and he says that this guy is not just a presenter, but also an inspiration. Keep it up. That's very good for you, Zachariah. I see
Other comments from Pauline Kimeo, where she says over 100 splints. Wow. Yes, KNH are actually doing their best. We are inspired, Zachariah. Well done. Yeah, so Zach, you've really inspired people in this talk that you've done. And as we continue forward, I'll ask guys, once we get done with the presentation, kindly just fill the feedback form. I've posted it on the chats. This feedback is very essential for us as Emergency Medicine Kenya Foundation. It allows us to see what you guys want and also be able to improve on our these talks that we have every last Saturday of the month. So I can see someone by the name of Redmi, I feel challenged. Yes, that is good. From Salin Jerry, well done, Zachariah and team. Good job. For sure, we become a solution to problems, not complaining. Yes, that is very true. We need to start being solutions to problems that arise. Anyone who wants to talk, you can just unmute yourself and give us a comment, kindly. Jeremy Gidome.
Hello.
Any comment? Yes, hello.
Hello. I was asking. This Saturday sessions are very good, and I'd like to acknowledge the speaker. He did a very good presentation, especially on the innovation and being prepared. I was just asking, especially for the people who work in the A&E, is there something that like a practical course for non-operative fracture management? Because we deal with this daily. I think majority of the people here could attest to that. We have maybe 2 or 3 or 4 fractures per day. So we put the back slabs, the splinting, immobilizations. So is there like something just to refresh? Because these things, it's either this Saturday courses or the last time we did it was in school.
Okay.
We use YouTube. Like practically, like how many layers of POP do you need to make a back slab? It's a practical thing so that it's not flimsy. Such things. Like the uses of the new things, I don't know, that new plaster of Paris is called what? I've forgotten the name. The one that uses the cold water instead of the one in the expensive hospitals.
Yeah, I'll tell you that. It's called Dynacast.
Yes, Dynacast. Yes. You see, such things. Because I know Dynacast is different from the other one. So like the practicability of having even 1 or 2 days, such
So thank you for that question and comment, Jeremy. I totally understand. I remember my first year after internship, I was in a private facility, and apparently it was the medical officers who had to fix POPs. And trust me, I did exactly like what you said. I went on YouTube, I looked at videos on YouTube, and that's exactly how I put up a cast on a patient. But yes, Zachariah, I think you can comment on that. This is a good idea. It's something that if you can develop it into a trainable program and something that you can just be doing for hospitals that have a high incidence of fractures, that patients who present with fractures at their emergency departments or their casualties, that can actually be something that is quite beneficial to people, especially when one of the things that you highlighted on is the use of borders that have become extremely rampant in the country. And now I know like our orthopedics department has majority of their fracture cases there. I think almost 80% of them are just from border accidents. And so this is something that I think we can look into. So Zachariah, you'll give us your comment, and then I can see Anne G also wants to have a comment. So Anne, you'll allow us first to have the reply from Zachariah, and then you can ask your question. Thank you.
Yeah, thank you very much. It's a good question. Practical is key. It's a very important thing. There is what is called non-operative fracture treatments training that is normally happening across Kenya. So non-operative is one of the courses that is normally held each and every year. And actually there are those, the AO has come up with this program. It is a 3-day program, very important, whereby they normally invite the doctors, the nurses, orthopedic trauma, the entire team, and especially those who are working at accident and emergency department. So we have this course called non-operative, the AO, whereby a team, like now there is a Western country, there is that maybe North Rift, there is Eldoret, there may be Kisumu. So there is specifically a date that actually has been set for this 3 days training. It's a very good training, whereby these practicals, like now application of plaster, you're actually taken through the entire video presentation, various like below elbow. How do you apply below elbow? Which fractures? Fracture radius and ulnar. How do you apply? Humerus fractures. How do you apply? Tibia fractures. How do you apply? Femur fractures. How do you apply? So this is an entire 3 days, very intensive and very good course about all the fractures of upper limb and the lower limb. So I'll just encourage that you keep on alert. This is a training where you are, maybe where you are, like which hospital you are working. And I think maybe Daktari, through this care of this foundation, I can actually be able to share when these trainings are normally held, so that your team that are working at accident and emergency department can actually be able to attend, because 3 days is whereby the videos are normally taken through, and then now practicals, the real practicals, how to apply plaster of Paris, when do you apply splints, when do you apply Dynacast, you'll be able to learn. It's a very comprehensive, you'll be able to learn all these practicals in that AO training program.
Okay, that is very good information, Zach. Thank you so much for that. I wanted to ask something. There's a question from Pauline who's asking, kindly specify what AO stands for. And as you're preparing to answer that, I'll just go through some of the comments. I'm seeing from Jeremy, I hope you've been answered. So yes, we'll team up with Zach and see how we can learn about this course and how we can use the Emergency Medicine Kenya Foundation as a maybe like a platform where we can get this training out to the hospitals within the country. Seeing there's a question here. Thank you. Thanks so much, Zach. This is from Benifa saying, thank you so much, Zach. I'm so impressed. How much is the hip spiker? How much is the hip spiker from a table from your hospital to Uganda? Hey, Zach, you're already getting queries about your innovation in East Africa. That is very good. Then from Tabi, she says, we've got so much from Zach. Thanks a lot. Can we maybe have a certificate? This was very educative. That's a good one, Tabi. Yes, we would love to give certificates, but there are certain thresholds that need to be met before we give out certificates, but that's a good point. From Angie, interesting presentation. Looking forward to many more. Thank you, Zachariah, and congratulations on your achievements. The innovation bit has really captured my attention. Well done. And then from Hughes, he says, thanks for the presentation. This is Dr. Hughes from Kinshasa, the Democratic Republic of Congo. I did not know before that POCAS can be used. Thanks, hope we meet again. And he has given us that POCAS can be used and says, thank you. Thank you so much, Hughes. Welcome. Thank you so much for joining us all the way from the Democratic Republic of Congo. We appreciate having an international audience, if I can say so. So we thank you very much. We will make this presentation available at our EMKF website once we're done, because it is being recorded, so that you guys can keep going through it and we see how we can help improve in the care and management of fractures within East Africa, because I'm seeing you have queries from Uganda, from Congo. So yeah, we're actually going places. So Zach, first of all, tell us, can your table be manufactured and sent to other East African countries, and how much it costs? And then, yeah.
Thank you very much for that good question.
Yes. Okay.
Allow me to say this. When we came up with this innovation for hip spiker table, I want to thank the government of Kenya, called Kenya National Innovation Agent. They support innovation. They gave us some grants, and these grants are able to do what's called commercialization, whereby we were able to come up with a company called Zakam, Orthopedic Innovation Company, whereby this company, we are now coming up with a lot of solution of medical to be able to solve our local solution. So apart from the hip spiker table, we've come up with a lot of products of medical to be able to solve a solution. Actually, our now hip spiker table, we've actually sold even one of the table to Makandishu. This one of the orthopedic surgeon bought our hip spiker table. So our hip spiker table, we can now be able to sell across the Africa, and even we are going now even to global, because most hospitals in Africa, they don't have this right equipment, and even globally. Actually, the other day, one of orthopedic surgeon in UK, he wants the hip spiker table with an extension traction. So one, we are now, if you want the hip spiker table, kindly, Daktari, you can give out our email company, our email details to whoever wants. You can now be able to get, especially now the improved hip spiker table with the mechanism. Actually, we can now be able to sell this in Africa and even beyond Africa. So you can get this hip spiker table. Then somebody asked about the AO. AO is one of the AO Foundation organization, especially it is for one of these orthopedic, the AO, where Daktari, or Dr. Peter Kamau Njoroge is the chair. It's one of the AO, normally deals with these fractures. So it's a foundation whereby they actually all the orthopedic surgeons, then they normally talk about the fractures and whatever. And a foundation that normally deals supporting all the caring about these fractures. Yes.
Okay, thank you for that. Thank you for that, Zach. Yes, we will get your contacts, and I'll share them on our Emergency Medicine Kenya Foundation of the organization website, so that anyone who needs to get in touch with Zach can be able to do that. I'm also saying that on the chats, there is Winnie Cheriot who's saying thanks for the presentation. She's all the way in Doha, Qatar. This is good, because you can see now our open mic talks are now becoming international, which is a good thing. Anyone else with a comment or an opinion and things like that? So maybe I could just give a small clarification. I think on Zach, when you're saying about the AO, I think that's the AO is the not-for-profit organization which has a global network of surgeons, and the premier education, innovation, and research organization for surgical treatment of trauma and musculoskeletal disorders. They have a website for the foundation. It's called the aofoundation.org. So for anyone who may be wanting to get more information on that, they can actually check that out. I've seen another question from Joshua Ochieng asking, excuse me, do these trainings involve all medical practitioners? Can you specify? Yes, well, in regards to what we deal with in the point about emergency medicine, and what we keep stressing about emergency medicine, is that for all of us, for a patient to survive, the skills have to come from all of us. It doesn't matter whether you're a doctor, you're a nurse, you're a orthopedic technologist, or any person, as long as you're working within the emergency department, that are very, very necessary for you to be able to help in the management of patients. So for Joshua, yes, they're for everyone, not just specific medical practitioners, but as long as you're working in the emergency department, that is the key point. So if you're working there, yes, definitely the trainings are for you. Okay, so I'm not seeing anything else in the chats, and I just want to thank everyone, especially Zachary, for your presentation. We have really learned a lot, and we've really learned a lot, and we are looking forward to more presentations from you.
Excuse me, Daktari. I've put my contacts there in the chat, and even my email. Whoever wants maybe to any hip spiker table, you can actually reach me in my email or even in my phone number. Yeah.
Oh, you've put them in the chat?
Yes.
Okay, because I can't see them. Just try and send them again. Okay. In the meantime, Joshua, yes, you can see you're a physiotherapist. Yes, we do have. In the emergency department, we have physiotherapists, and every single person has a role to play in regards to management of critical, in management of emergency and critical care patients. So most of these trainings, yes, they are for everyone, though there are some trainings that we do as the Emergency Medicine Kenya Foundation, which sometimes are tailored specifically for certain cadres. But yeah, most of the other trainings, yes, definitely you do need to, as long as you're working within the emergency department, that will actually be a good thing to thank. Yeah. So as Zach is adding his credentials to the chat, I'd just like to thank him for the presentation and to thank every single one of you for joining us this morning. I know it's a Saturday morning, and thank you just for taking your time out to come and join us and learn a bit more about how to manage fractures in the emergency department. We really do appreciate you. And just to remind you to kindly just fill the feedback form that is at on the chat box. You can find it there, and just yeah, do that. Tabi Chege, I see you're unmuted. Would you like to say something before we close? Oh, okay. So Zach, have you been able to share your news on the chat?
I've sent in a chat. I don't know. You're not able to see.
But I'm looking at the chats right now. I'm not seeing it. Or maybe you can send it to my WhatsApp. Then I can add it to the chat.
Okay, doctor.
Yeah. Okay. Then just to remind you guys that the Emergency Medicine Kenya Foundation can be found on all, we're on all social media platforms. Just type Emergency Medicine Kenya Foundation. You'll be able to get us on Facebook to get more updates. On Twitter, we run 2 accounts. And just for a quick dissemination of emergency updates. And also you can find us on our website, which is Emergency Medicine Kenya, emkffoundation.org. And there you'll be able to get every single thing, including our books on how to deal with emergencies, which you can download for free. And also get the recordings of these talks that you have had, which you can actually just get them on the website as well. Once this one has been prepared and it will be uploaded into the system, then you can be able to access it. Gladys Mudiani says, wonderful presentation. Thank you so much, Gladys. We enjoy. We're glad that you guys have actually enjoyed being here with us today. So I'll just share Zachariah's contacts so that you guys can be able to reach out to him. Anyone who will want to get a hip spiker table or just learn more about how to manage fractures and how to deal with all these things that come in the emergency department. So I'm just posting it right now. All right. Okay, so they're there on the group chat. You can see them, his email address and his phone number. So guys, if you feel you need to, you can join them. Oh, for Joshua, our social media accounts. Basically, our social media accounts just go to any social media, whether it's Instagram, Facebook, or Twitter, and just type EMKF. You'll be able to get them. You'll notice it from our logo, which is let me see if I can find the logo and show you. Just like a second. Yeah. Okay. In the meantime, Zach, any last words?
Yeah, just want to say thank you for everybody. Thank you for listening. I believe the message to take to your hospital or where you are working is to have the right equipment, to have the right tool, so that to be able to manage and immobilize these fractures correctly. So just want to thank everybody. Thank you for listening. I'm always ready. I've been sometimes called even to go and give a presentation in some of the hospitals. So I'm always free. I'm always available, always ready. If you want me to give you, to come and even give a presentation in your hospital, practicals about these fractures or anywhere, I'm always available and I'm always ready. I just want to wish you all the best. Let's manage our fractures well. Let's manage our patients well and give to the best and come out of your box and then be a solution to a problem.
Yes, thank you so much, Zach, for those inspiring words. I've shared our email address. Okay, sorry, our website, EMKF@EMK Foundation. We also have our Twitter account at EMKE Foundation. So you can start with those ones. So Joshua, those are our social media platforms. You can check from there. So guys, thank you so much. I'd like to
before you finish.
Oh yes.
I've just remembered something. You had this program for facilities for the equipment, like the POCUS and the ECG. Is it still
Yes.
running, and how can we apply for that program for the facilities?
Yeah, so that program is under what we call the emergency care course, which is a tech, what we call tech training. Well, it's a separate from counties. So which county do you come from, Jeremy?
I work for a mission hospital in Thika.
A mission hospital in Thika.
Yes.
Okay. Jeremy, I think what I'll do, I will give you my contacts, and then I can try and get out, because most of the training that we have been doing and also the equipment that we have been giving out has been to county, to specific counties, and then they identify the specific county hospital. We haven't yet done for mission hospitals, but that is something that we can come out. So I think I'll just I'll just let me send you a chat right now just to give you my contacts. Then you can reach out, and then we can see how we can, how we can assist you guys.
Okay.
Okay.
That would be helpful. Thank you so much.
So to the rest of the people who have joined us, I want to say thank you so much for giving us. And again, have a lovely, lovely weekend, and see you the last Saturday of the month of August. Do have a lovely weekend. Bye-bye.